for a patient that you are now concerned that they might have a plasma cell disorder, maybe they have some of the crab symptoms, and your level of concern is high. How do you take that patient and really diagnose them with the disorder, whether it's smoldering myeloma or multiple myeloma? And really the question is, how do you differentiate patients with MGUS, smoldering myeloma, and multiple myeloma?
Yes, great. So we did revise the diagnostic criteria in 2014, and so I'll use those criteria. Prior to that, um, if you had crab features, it was myeloma. If you didn't have crab features, it was either MGUS or smoldering. And MGUS was less than 3 grams, less than 10% plasma cells. Smoldering was 3 grams or 10% or higher plasma cells. Either one was smoldering. But both of them should not have crab features. But if you had crab features, it automatically became myeloma. So that was pretty simple in prior to 2014. After 2014, the only major changes are that if the bone marrow involvement is 60% or higher, it's automatically myeloma. So smoldering, instead of more than 10%, became 10 to 60%. 60 and higher becomes myeloma. We also added some myeloma defining events because we wanted patients to be started on therapy before they had end organ damage, not after. And unlike other cancers, myeloma was unique because the diagnosis of the malignancy was not dependent on the pathologist. Whereas with, say, breast cancer or colon cancer, the pathologist says adenocarcinoma of the colon, then it doesn't matter what size the tumor was, it's a cancer, and that's how you're going to treat it. Whereas in myeloma, they just tell you clonal plasma cell disorder consistent with MGUS, myeloma, blah, blah, blah. So we were in a catch-22. We didn't want patients to get crab features and only then be called myeloma. At the same time, we didn't want to treat people too early and then be treating people who have MGUS. So a compromise was made that patients who are kind of inevitably going to get crab features in the next year or two should really be called as myeloma, and we shouldn't be waiting on them. So that's why we have started the criteria we revised. 60% or higher is enough to call it as myeloma, regardless of whether the patient has crab features or not on the bone marrow. Now, same thing with the light chain ratio. The normal ratio, as we talked about, is like within 0.26 to 1, 1.65. But if the ratio is more than 100, involved over uninvolved, that's very high, markedly high. And in those levels, the kidney can be damaged. And so we call that as also myeloma, with some caveats that the urine should be positive. You don't want the urine to be, you don't want this to be a false positive. So urine should show significant monoclonal protein in the UPEP. And if the ratio is higher than 100, that's also myeloma. And then if you have focal lesions on the MRI, even before lytic lesions show up on the bone survey, that's also myeloma. So myeloma is now defined as clonal plasma cell disorder plus any one of the 7 myeloma defining events, which is the crab features attributable to the plasma cell disorder, or 60% or higher plasma cells, more than 100 light chain ratio, or more than one focal lesion on the MRI. Anything other than that is either MGUS or smoldering, and they are differentiated by the M spike less than 3, bone marrow less than 10%, that's MGUS, any 10% or higher, or if the M spike is more than 3, that's smoldering. Keep in mind that for many of the MGUSs, we are not doing a marrow, so we had decided that they have less than 10%. So it's less than 10% if a marrow was done.